Well, thank you all for being here, for your attention for the next 15 minutes or so. As I speak, I'm going to talk about two treatment options for prostate cancer, for localized prostate cancer, that I conduct, in that surgery and focal therapy. Neither of my disclosures here are relevant for the content of this talk. So just at a kind of a global level, when we think about treatment options for prostate cancer, and you're going to hear a lot more about this later today as well, we have active surveillance or just closely monitoring men with low-risk prostate cancer without treatment. On the other end of the spectrum, we have whole prostate treatment, either with surgical removal or prostatectomy or radiation therapy. And these remain the mainstays of treatment. And then kind of a middle ground approach is this idea of focal therapy, or a partial prostate treatment, and we'll talk about that as well. But the primary focus of the next 15 minutes, again, will be on prostatectomy and on focal therapy. I'm going to start by talking about prostatectomy, and that's because it, along with radiation, again, remain the mainstays of treatment and have for many decades now. These are what are in the prominent clinical guidelines, such as those through the NCCN, or National Comprehensive Cancer Network. So let's talk about prostatectomy first. Initially, a bit of a historical perspective. Prostatectomy is not new. It was initially described back in 1905 by a famous urologist named Hugh Hampton Young. This is at the same time as this was a state-of-the-art 1905 Ford Model C automobile. So this has been around for a long time. In 1984, there was another fundamental breakthrough made by another famous urologist, Pat Walsh, at Johns Hopkins, who described the nerve-sparing prostatectomy, which can lead to lower rates of side effects in men undergoing prostatectomy surgery. And then in 2000, the first robotic radical prostatectomy was performed. And now, today, the vast majority of prostatectomies done in the United States are done using a surgical robot. So why do we do prostatectomy in the first place? Well, the evidence for this, probably most importantly and earliest, came from a randomized trial conducted in several Scandinavian countries that was initiated back in 1989. And in this trial, the investigators took about 700 men and randomized them, essentially flipped a coin, and if you were heads, you ended up having a prostatectomy, and if you were tails, you had watchful waiting. So no treatment, just monitoring over time. And the question was, is if you're treating guys who get treated, are they less likely to die of prostate cancer? And this is the result from the study, the key slide. The quick answer is that yes, there was a reduction in death of prostate cancer. And I want to try to take you through this to describe what we're looking at. So on this x-axis here, we can see time, in this case going out to 15 years after the initial decision of surgery or watching. On the y-axis, we see the probability of death of prostate cancer. So the higher you are means a higher chance of having died of prostate cancer. And these lines here tell us what happened over time. So the black line represents the men who had surgery, and the gray line represents those who had had watchful waiting. And what we see here is that these two lines separate from each other. The black line is lower, meaning that fewer men died of prostate cancer in the group who had surgery. Now you notice that still some men who had surgery died, and many men who did not have surgery did not, but there is a difference between the two. And what the investigators saw is by 23 years of follow-up, which is a long time to follow people for medical studies, there was a difference, again, in death rate. So if you had nothing, you had watchful waiting, the chance of dying of prostate cancer was 29%, and if you had surgery, it was 18%. So a difference of 11%. And this is the reason why we still do this, because it does save some men's lives. Now, how is this performed? Traditionally, for a long time, this was done with open surgery, an incision made from the belly button down. And more recently, there's been this transition to robotic surgery, where instead of one large incision, we make several small holes in the belly. And through those holes, we place ports, which are essentially access channels that allow us access to what's going on inside the body. And then in the operating room, the surgical robot is attached, snapped onto each of those access ports so that the surgeon's able to control from a console in the same room what the robot is actually doing. This is an image from a patient who is undergoing surgery. And what we can see here, and this is a little video that's going on from a case that I did relatively recently, you can see how the arms are moving around in the body. And what I'm doing at this point of the operation is separating the bladder, which is in the bottom of the picture, from the prostate, which is the round thing up towards the top of the picture. And this is just one of the many steps of this operation. And this is what the surgeon sees during the time of the surgery. So afterwards, about a week or two later, we get a final pathology report back. The pathologist will look at the tissue under the microscope and tell us, was this aggressive or not? Was the cancer extending outside the prostate or not? And they can also give us a visual representation of how big the cancer was and where was it within the prostate. What they've done here is essentially taken the prostate and sliced it up like a loaf of bread. And this is one slice of bread, if you will, and they take an image of it and draw the areas of cancer in green. And so you can see all these areas that are circled in green are areas of cancer. And in this particular man, he had quite a lot of cancer. It's on both sides of the prostate, multiple different spots of cancer. So very reasonable to do a treatment addressing the entire prostate, like removing the whole prostate, or doing radiation. Now, we said that we can reduce deaths of prostate cancer by doing surgery, so why not? And we don't really need our prostates anymore once we're done having kids, so why not get rid of the prostates in everybody? And the quick answer is side effects. With surgical removal, urine leakage and loss of sexual function are the two most common side effects. And I want to highlight a figure from a nicely done study that was published in JAMA, a prominent medical journal, that looked at sexual function and sexual dysfunction following different treatments for prostate cancer. And so I'll take you through what this figure tells us. We can see on the x-axis is time in months extending out to 3 years after treatment. On the y-axis is the probability of having sexual function that's good enough for intercourse. The green line are those men who did not have any treatment, who were on surveillance for their cancer. The blue line is those who had surgery, and the pink line are those who had radiation. And a few observations from this. We see in those guys who did not get treatment, pretty much stable sexual function out to 3 years of time, a fairly flat curve. In men who had surgery, we see the precipitous decline immediately after surgery. And then in some men, they get recovery of function over time, and then it flattens out. And in men who had radiation therapy, we see a decline, albeit not as much as with surgery, and then it flattens out. So it tends not to then come back. And we see that whether you have surgery or radiation, the chance of having good sexual function is lower than those men who did not get treated for their prostate cancer. So the question is, why is the starting point for radiation therapy lower than the starting point for the other two? And there are probably several answers to this. One example may be that on average, men who have radiation treatment for prostate cancer tend to be somewhat older than men who have surgery, so more likely to be suffering from erectile dysfunction. So that's why I say that even though these lines are superimposed with each other, we do see a more significant decline with surgery, which had a better starting point than with radiation. Also in this study, the authors observed that in most men who had good erections before treatment, so imagine they were all starting it at 100%, the proportion with erections that were good enough for intercourse at 3 years was just 43% after surgery and 53% following radiation. So not so good. Definitely still appropriate treatments if the cancer is bad enough, but not something we're going to want to do in absolutely everybody. Now let's talk a little bit about just the prostate cancer care continuum and how we find prostate cancer in the first place. Most often this is detected with a PSA blood test. which then leads to what I'll refer to as a blind biopsy, and I'll describe in a minute why I call this blind. And then if cancer is detected, going on to treatment with surgery or radiation. Now, the reason why I'm saying this is blind is that the best imaging modality that we had available to us for many years was ultrasound. And this is a sample image of a prostate in transrectal ultrasound. You see the prostate as the structure right in the middle of the screen. And ultrasound shows us very nicely where the prostate is, where the edge of it is. But what it doesn't do is it tell us where the cancer is actually located within the prostate in most cases. And so prostate biopsy for diagnosis evolved not by seeing something and targeting it, but more using ultrasound to find the prostate, and then evenly spaced needle sampling throughout the prostate to try to find cancer. And this works much of the time, but as you may imagine, there are sources of error, such as that represented here, where you can see these biopsy cores, individual pieces that we take in black, may miss the cancer represented in red just by chance, because we're not specifically aiming at it. Now, fortunately, starting 10 to 15 years ago, and increasingly of late, we do have better imaging modalities available to us in the form of MRI, which allows us to see many, if not most, prostate cancers in the prostate. So you see in this case, this dark area is a suspicious area, the area of cancer. And once we have an imaging test, then we can target our biopsies at that area to improve our chance of finding cancer. And the most common way that this is done is with a technique called MRI ultrasound fusion targeted biopsy. So instead of going straight to biopsy from PSA, you go and get an MRI. The radiologist will then look at the prostate, see any areas that look suspicious, mark out the edges of prostate in multiple different dimensions that generates a 3D model of the prostate based on MRI. And then at the time of the biopsy, I do the same thing using ultrasound guidance, marking out the edge of the prostate in multiple planes, generating a 3D model on ultrasound. And the technology we have allows us to line up these two three-dimensional models so that we can target areas in the clinic under ultrasound guidance, even if that spot is only visible on MRI. And there have been a number of nicely done clinical trials to date that shows that we improve the chance of finding aggressive prostate cancer using this approach. Now, I want to move on a bit to talk about precision medicine, which is a term that's been mentioned already here this morning. And to me, precision medicine just refers to this idea of not treating every person the same, to individualize decisions based on differences in clinical conditions, in health, and personal preferences. Now, we showed this image earlier of a man who had a prostatectomy. It shows quite a lot of cancer in multiple areas in the prostate. And this is a separate patient, a different man, both of whom had a prostatectomy surgery, but this guy has a much smaller cancer circled in green. And the idea of precision medicine is, well, can we treat these two men differently? Because clearly their cancer is quite a bit different. And that's where the idea of focal therapy comes in, which I'll define as the targeted destruction of cancer while preserving normal surrounding tissue. So in this case, trying to just zap this portion of the prostate containing the cancer while preserving the rest of the prostate and surrounding structures with the goal of reducing side effects. And this has been referred to as the male lumpectomy because it's analogous to doing a lumpectomy rather than a mastectomy for women with breast cancer. This has been shown to have reduced rates of side effects, has good cancer results, at least out to about 5 years or so in nicely done studies, mostly in Europe. Although we do not have the randomized trials that I mentioned, the Scandinavian trial for prostatectomy to date to show us to what extent lives are being saved with this approach. But in terms of destruction of the cancers, the results look quite good, at least in the short term. This also importantly preserves the option for surgery or radiation if it doesn't work. If cancer comes back either near the area where the cancer used to be or elsewhere, we can still do surgery or radiation as necessary. Now, I don't have time to talk about all the different methods available for focal therapy, so I'm just going to focus on one, which is called HIFU, or high-intensity focused ultrasound. Think of this as analogous to taking a magnifying glass outside on a sunny day and focusing the sun's energy on a leaf and burning a hole in a leaf. Except in this case, instead of using the sun as our energy source, we're using ultrasound and focusing that ultrasound energy into a small point that gets very hot and destroying tissue by heating it. And in the case of HIFU for prostate cancer, what's done in a man in an operating room setting under anesthesia, we put a probe through the anus into the rectum, and then ultrasound energy is directed into the prostate to heat up whatever areas we want to try to eliminate cancer. This is not invasive, so there's no cuts on the skin made because we're just putting this probe in through the anus. It works by heating, so this is different than radiation. It's killing cancer just by temperature. It's a one-time outpatient procedure, so it takes about 2 hours or so, and men go home the same day. And this is an example patient, just to get an idea of what we're looking at here. This was a 64-year-old man who had no symptoms, which is, again, very common for localized prostate cancer. PSA was high, which led to concern, so he had an MRI that was done. And that's seen here when we can see this dark area that's suspicious for prostate cancer. So he had a targeted biopsy procedure performed, showed cancer in that area and nowhere else, and he elected to have an MRI-guided HIFU treatment, essentially. And what we see is immediately after the treatment, the area that cancer was present is now black. And that's telling us that there's no more blood going into that area. So that tissue is dead, but the rest of the prostate is preserved. And this man did very well. PSA dropped nicely. A follow-up biopsy showed no more cancer and had good sexual function preservation. So a really nice option for select patients. So what are the take-home points from my talk this morning? Number one, I think that both surgery and focal therapy are good treatment options. Neither is going to be the best option for all men, but both have their role. And the goal, as I think about this as a urologic oncologist, is to try to save lives while at the same time reducing the harm from treatment. And some of the new technologies that we have and we talked about just now are helpful. This MRI-targeted biopsy and focal therapy are both things that can really help achieve these two goals. Thank you for your time and attention. I'll leave our phone number up here for anybody interested in scheduling a visit with Stanford Urologic Oncology, and happy to take any questions.
Thank you so much, Dr. Sonn. For questions, please give us your cards. We'll go ahead and answer them over here. So I'm going to go ahead and start with a few questions. Number one, after focal therapy, patients require catheters for 5 to 10 days. After prostatectomy, they require them for 10 days. Why do we need a catheter for so long after these procedures?
After focal therapy, it depends a little bit on what type we get done, but in general, it's very common to have a catheter for at least a few days, if not longer, depending on what we do. What can happen is there can be some swelling in the prostate for a short period of time. And if we don't have a catheter to drain the urine, it can become completely obstructed and not being able to urinate. So having a few days with a catheter allows that swelling to go down. That's with focal therapy. In men who have prostatectomy surgery, so we saw that part of that video, I would go on to remove the entire prostate. The bladder flops down into the pelvis, and then we sew the bladder to the urethra, the tube where the urine passes through the penis. And then a catheter goes up through there to allow the urine to drain while we're waiting for the bladder to stick to the urethra, to heal to it. And once it's healed, then the catheter can be removed, and then a man will urinate through the penis again.
Thank you. Another question. Are you able to do additional treatments after focal therapy?
One of the nice things about focal therapy is that it does preserve options for afterwards. We can do focal therapy again if we find over time that either cancer comes back near where it used to be or elsewhere. If we can see it on imaging and prove it's cancer on biopsy, then repeat focal therapy is an option. But if we decide that more focal therapy is not going to be helpful, we still can do surgery or still do radiation. So the options remain available for backup treatments when needed.
Are focal therapies an option for patients who have macroscopic extracapsular extension protruding from the tumor?
So this question is referring to situations where the prostate cancer may be extending outside the capsule or the shell of the prostate. And macroscopic tends to mean that there's a bigger amount of extension outside of the prostate. So the quick answer is it depends, but often not. Typically, if we're seeing a big, bulky cancer that's clearly growing outside of the capsule of the prostate, we tend to be more aggressive with treatment with either surgical removal or radiation. In situations where there's a small amount of extension of the cancer outside of the prostate, focal therapy does seem to still remain a pretty good option.
Regarding sexual function and recovery after prostatectomy, if people are able to get normal or improved erections, do they require medications, or is it usually without medications?
As we showed earlier, after surgery, loss of sexual function is extremely common, and almost all men will experience that initially, and then some will regain that over time. I think there's a talk later today that talks about this process of recovery of sexual function and how we can facilitate it after any treatment for prostate cancer. The studies in general consider success to be, in terms of regaining function after surgery, to be either with or without medications. So when you read these publications, most will say a man who has good function without medications before, who afterwards needs medication to have function afterwards, is still considered a success. So most men who have preserved function do need medications. On occasion, we do see guys who tell me, my sexual function's close to as good as it was or as good as it was before surgery without medications, but that's the exception rather than the rule.
Can you do focal therapy if you have more than one tumor on the same side or on different sides of the prostate?
I do still tend to offer focal therapy if we'll find two tumors on the same side of the prostate and then just encompass those two cancers within the same plan-treated area. When you start to have one cancer on one side and one on the other, if they're high enough grade, if they're both significant, I move more towards a whole prostate approach like surgery or radiation rather than focal therapy, unless we see one bad cancer on one side and a little bit of low-grade cancer on the other side, often not even visible on imaging. In those cases, we can do focal therapy to the cancer we're worried about and just leave the other one alone, under the idea that if all they had was that other one, we wouldn't be doing anything about it in the first place.
What makes a good candidate for focal therapy? The Gleason score and other factors?
The ideal candidate is someone with a Gleason score of 7, and I say 7 because Gleason scores of 6 in general are better served not to do anything, and the Gleason scores of 8, 9, and 10 have a higher chance of metastasis or spreading elsewhere. So the sweet spot is a Gleason score of 7, ideally something that's visible on imaging, so we can see it nicely on the MRI, and we showed some sample images today. The biopsy shows that cancer is present in that area that was abnormal on the MRI, and either no cancer outside of that or only a small amount of low-grade cancer. That's really the sweet spot for focal therapy.
How do you decide, and I know Dr. Chen will also speak about radiation, but how do you decide between having surgery or radiation, in your opinion?
That usually ends up being about a 45 to 60-minute conversation, at least once in the office, to talk about differences in outcomes and side effects. In general, I'll tell patients that the cure rates tend to be comparable, so the decision-making is often one based on differences in the side effect profiles. Examples: surgery tend to have a higher risk of urine leakage afterwards. Surgery, slightly higher risk of loss of sexual function. Radiation may have a higher chance of bowel and bladder dysfunction, causing things like more frequent urination or diarrhea or bleeding that's often temporary, but in some cases can be long-term. So it's often a choice between one set of undesirable side effects versus another set of undesirable side effects, and just some personal preferences then too. There are things like, age and whether someone has had a lot of prior abdominal surgery, and a number of other factors that the doctor will take into consideration in making a recommendation towards one or the other. But in many cases, it comes down to the patient making a final call.
Thank you. And final question. After having focal therapy, what is the best thing that can be done to prevent it from recurring?
Many of these things we don't have a lot of control over personally. I think there are a few things to do. One is to continue to follow up closely, so if it does come back, we learn sooner rather than later when there may be more options available to us. And the follow-up is similar to after surgery or radiation with PSA blood test regularly, imaging, and I get a biopsy at a year afterwards to assess where we are and whether there's cancer still seen there. The other thing that I'll talk to patients about is just the importance of controlling the things that we can control. So we can all control how much we exercise, we control what kind of food we put in our bodies. And so I try to get patients exercising regularly. And there is evidence that a vegetarian diet or a Mediterranean diet can be helpful. Those things can be helpful for the prostate and also helpful for the heart. And recognizing that the majority of men with prostate cancer die not of prostate cancer but heart disease, it's important to do things that are both good for the prostate and for the heart.
All right, 2 more questions. I lied. What percentage of patients have you seen that have had to have another procedure after HIFU? And then is there an age limit of patients that can have these procedures?
There's no real age limit for this. And what proportion need additional treatments is, it depends a bit on how closely we're looking for it, and it remains somewhat debatable. In what we've seen from patients treated here, between 20 to 30% of men on their follow-up biopsy are still found to have a Gleason 7 or sometimes higher prostate cancer. Oftentimes it's a bigger cancer that goes to a much smaller one, and if it's really small, we'll often continue to follow those over time, so you don't necessarily need to get treated again right away. But sometimes it can be a bigger amount, or the PSA is going up, the imaging is concerning, and in those cases, those are patients that may either get focal therapy again or go in to have surgery or radiation.
Great. Thank you so much, Dr. Sonn. A wealth of information. Oh, we have one more question. I'm going to give you the microphone.
No, that's all right. I want to ask myself. Dr. Sonn, number one, you treat, when the Gleason is equal to more than 7, you do focal, which is part 3. What's the repeat percentage, would you say, for focal?
So I think the question is regarding to the need for retreatment. And just to clarify again, most of these patients I'm treating with have Gleason 7 cancer. With the higher ones, the 8, 9s, and 10s, it's less common, although we've done it in some guys, particularly older guys who want to avoid a long-term course of radiation and hormonal therapy to try to debulk a higher grade tumor. But most of these are in Gleason scores of 7. And that's what I was mentioning a second ago, that we've seen 20-30% of guys that will still have Gleason 7 cancer in follow-up, some of whom will get treated at that point, and other ones will continue to monitor.
So what's the focal repeat percentage?
I tend to, there was a nicely done study that was done in the UK in 625 men who were treated with focal HIFU, and they ended up redoing focal therapy at least once between 20 to 25% of men.
20 to 25%. So we're talking average of 22% or something. Okay. Question 2. After focal, when do you need treatment for full treatment percentage?
So the question here is afterwards, what proportion of men after focal therapy need a radical therapy, surgery, or radiation? And from that same trial I mentioned a bit ago, about 10% of men over the course of 5 years of follow-up went on to getting either their prostate removed surgically or radiation.
10%. Okay, thank you.
You're welcome.
Okay. Thank you
All
so
right.
much, Dr. Sonn.
Thank
We
you,
appreciate it.